Hello, welcome to the monthly teaching video of Safe Space Community for Asians. SSC seeks to equip you with holistic remedies for emotional and mental health difficulties from the medical, psychological, spiritual, and relational perspectives by integrating psychology and theology. This is session number 8. I am Dr. Edmund, a licensed psychotherapist, and I am your facilitator in SSC. The title of today's topic is Obsessive-Compulsive Disorders, or commonly known as OCD. You will learn, first of all, what is the nature of an OCD, and then I will talk about the etiology or the cause of an OCD. And then I will cover the medical treatment aspects of OCD. Although drugs can help to reduce the symptoms, medical treatment has to be combined with psychological interventions. So I will cover 2 protocols that are considered to be most effective for attending to OCDs. The first intervention is called the exposure and response prevention therapy, and the second is memory reframe psychotherapy. Finally, I will end with the subject of how to relate to people with OCDs in a helpful manner. Now, before I start, let me say a word about the prevalence of OCDs. Some 2.3% of the world population has OCD. This works out to about 1 in 40 adults and 1 in 100 children. The prevalence of OCD is higher in females, 1.8%, than in males, 0.5%. In families with a history of OCD, there is a 25% chance that another immediate family member will develop the symptoms. More males have early onset of OCD before 10 years old, while more females have OCD during adolescence after 10 years old. But the average age of the onset of OCD is 19.5 years old. Now about the nature of OCD. What is an OCD? OCD is defined by the presence of an obsession or obsessions or a compulsion or compulsions or both together. What is an obsession? Obsessions are recurrent and persistent thoughts, urges, mental images that are intrusive and unwanted, thus causing anxiety and distress. The person then attempts to ignore, suppress, or neutralize them with a compulsion. And what is a compulsion? Compulsions are repetitive behaviors or mental acts performed in response to an obsession or according to some self-made rules that are applied rigidly. They are aimed at preventing or reducing the anxiety or distress or preventing some dreaded event or situation. So as a result, the OCD often causes impairment in social, occupational, or other important areas of functioning. Now, let me illustrate the OCD in the form of a cycle of the OCD spike. First of all, you have the trigger. A trigger means something that is noticed in your physical, social, or mental world. And the trigger immediately activates an obsession. Obsession are thoughts, feelings, and impulses which are anxious or distressful. And that obsession immediately creates a distress in the form of fear, guilt, anger, a dread, or a combination of emotions. And the distresses causes repetition of certain actions called compulsion. The purpose of the compulsion is to get a temporary relief from the distress. And the cycle goes over and over again. So about compulsions, there are the external symptoms that we see. What are some of those external symptoms? Symptoms such as the repeated cleaning and hand washing, constant checking to see that the door is locked or gas is turned off, ordering of the same items over and over again, counting repeatedly to make sure something is correct, saying quietly the same words over and over again, rearranging items of furniture continuously, or persistently rebuking the devil throughout the day. Now, compulsions can also have internal symptoms. And some of these internal symptoms include the repetitive mental attention given to the obsessive thought, or they can be seeking distractions, keeping busy all the time, listening to music, chatting continuously, and this is very common, excessive worry, or inflicting self-injury. And there can be avoidance, repeated avoidance of the obsessive thoughts by negating or reasoning against them. You see, obsessions are irrational thoughts with emotions, but challenging them by reasoning is fertile, as our brain's emotional connections are stronger than the rational connections. Reassurance seeking can be one of the very common internal symptoms, but reassurance only offers a temporary relief. And so a compulsion is a forced, fear-blocking repetitive ritual, as it only grants temporary relief to the distress. Now, there are some other disorders which are related to OCDs. The first one is called the body dysmorphic disorder. It is preoccupation with one or more perceived defects or flaws in the physical appearance that are not as observable or appear slight to others. The person is always mirror checking, glooming, reassurance seeking, or comparing with others. Then there is a hoarding disorder. Hoarding disorder is the persistent difficulty in discarding or parting with possessions that are of little value due to a perceived need, resulting in the accumulation of items that congest and clutter. And third, there is this hair pulling or skin picking disorder. This refers to the recurrent pulling out of one's hair or skin picking, despite repeated attempts to decrease or stop such behaviors. Now, whether it's the OCD or the related disorders, we can group them into 3 levels of severity. The most serious one, the severe impairment. The person is often completely convinced that the OCD beliefs are true. In other words, we call them ego-symptomic, or they are in denial that the symptoms are abnormal. And some 50% of adults with OCD are in this category. Then the moderate ones. This person often thinks that the OCD beliefs are probably true. And some 35% of adults with OCD are in this category. Then the mild cases. The person often recognizes that the OCD beliefs are not true. We call them ego alien, or they are in agreement that the symptoms are abnormal. And only about 15% of adults with OCD are in this category. And so with that, let me talk a little about the etiology, or what causes OCD. First, there is this hereditary reasons. Genes can play a part, as OCD often run in families. It involves the malfunctioning of a neurotransmitter called serotonin. Serotonin is a chemical messenger of our brain. And then OCDs can be caused by the formative experiences of the person. Controlling caregivers who have set up during the person's childhood some power struggles in areas such as eating, obedience, toilet training, or sexuality. And when a person develops OCD, they believe that others are always trying to exert control over them, and so they must resist. They believe about themselves that the aggression in them is dangerous, and such aggression must be controlled obsessively and or compulsively. And so these beliefs cause the person to have OCD symptoms. And so we come to the medical treatment of OCD. Selective serotonin reuptake inhibitors are the drugs used to regulate the level of serotonin in OCDs. Examples of SSRI are Prozac, Praxil, Zoloft, Celexa, and Lexapro. And for very severe symptoms of OCD, an SSRI is combined with chlorpheniramine, which is a non-selective SRI, to regulate other neurotransmitters besides serotonin. And the medication takes about 12 weeks to show the results. Now, medication works best in combination with psychological treatment, as it allows the latter to be more effective in helping people to learn how to prevent or eliminate the compulsions. The first protocol that I like to go through with you is called the Exposure and Response Prevention Therapy, or ERP. ERP is a cognitive behavioral therapy, and it involves the exposure of the thoughts that provoke the obsession and helping the person to make the choice not to carry out the compulsive behavior as a response prevention. As an illustration, if your house alarm goes off every now and then for no valid reason, you can learn to accept that it is a malfunction and refuse to check the whole house for any unwanted intrusion unless the alarm is repaired. These are the steps it involves. Step 1, select a trigger, an obsession-compulsion combination that is least stressful. What is least stressful can be self-assessed using the subjective units of disturbance scale. Now, this is the scale. It ranges from 0 to 100. 0 representing no distress or totally relaxed, and 100 means the highest anxiety that you ever felt. So the SUDS is a self-assessed subjective scale to rate one's intensity of disturbance or distress currently experienced by the individual. And step 2 involves practicing the exposure by bringing on the obsession either in reality or in imagination. Once the distress is confronted, it becomes not as distressful as anticipated. Just like when you have anticipatory fear of something, and once you are involved in that something, the fear will reduce. The obsession will stop to trigger fear and becomes just thoughts which are without emotions. Step 3 is to practice response prevention by not resorting to do a compulsion for the duration of the shaping and desensitization exercises, which is step 4. And a compulsion is really a forced fear-blocking behavior. So in step 4, you practice the shaping and desensitization exercises every day for 1 hour. Shaping means to start with an obsession that causes only minimal distress until you have little or no reaction to it. Then proceed to the next obsession that is more distressing until all the obsessions are exposed. Then desensitization means to expose one to an obsession long enough until the trigger is neutralized and the distress is completely gone. Thus, the person will experience the obsession as desensitized, and there is no more urge to resort to the use of a false fear blocker, that is the compulsion. The next protocol that I wish to go through with you is called the Memory Reframing Psychotherapy, MRP. If the OCD is rooted in a past trauma or shame. Compulsions are seen in NLP as a defense mechanism that prevents the memories of the past trauma or shame from surfacing. So MLP is a psychodynamic technique to restructure the negative memory of the past trauma or shame to something positive so that the use of a defense mechanism becomes unnecessary. As an illustration, if a child was traumatically shamed in school for defecating herself due to a sudden bout of diarrhea, she can end up feeling dirty all the time and constantly washes herself. The repeated washing is a defense mechanism to avoid the risk of triggering her shame memories. So MRP seeks to reframe the memories of the past shame incident. Now, to understand the process of MRP, we need to know the neuroscience aspects behind it. Unresolved past traumatic or shame events are stored in our memories. Memories are formed by the reactivation of a specific group of nerve cells called neurons through the persistent changes in the strengths of connections between them. The persistent change in the strength of the connection is termed synaptic plasticity. Neurons that fire together wire together. These past toxic memories can be restructured through the creation of healthy reparative memories as alternative routes for the synapses to travel on when a particular trauma or shame memory is triggered. The good news is that we can create the healthy alternative routes without reliving those events in real life. So neuroscience researchers have found that mental imagery can change our multi-sensory perceptions. In other words, our imagination can create reality at the neuronal level. And to be effective, unresolved trauma or shame memory reframing through imagery has to be experienced as real as possible. The experiencing is the key to effectiveness. And what the process involves. Step one, first we psycho-educate the person to be more aware of how they react in the face of a particular trauma or shame. Then step two, we get the client to relax, close the eyes, and imagine walking into the past memories. Then step three, we zero in to the most relevant trauma or shame incident. This incident, we call it the governing sin. In step four, we lead the client to re-experience the governing sin as real as possible and verbalize the consequence and the emotion embedded in the memory. Step five, we ask the client to imagine bringing into the governing sin someone who can rescue him from his acute trauma or shame during this incident. The rescue means the person is able to change the outcome of the imagined incident to a favorable one. In step six, we reinforce the favorable memory by asking the client to verbalize the new emotions now experienced by him. And the last step, we bring the client back to awareness and debrief on what has taken place. So the purpose of MRP is to repair the trauma or shame of the original experience, to create through imaginary a favorable memory out of the same past sin as an alternative route for the memory synapses to travel. And this is the whole protocol that is called memory reframing psychotherapy. Now, I'd like to finish this teaching video by talking on how we can relate to people with OCDs in a helpful way. First, we need to be patient with them and non-retaliatory when we see their irritating behaviors. We need to avoid any power struggles with them so that we are not perceived as one of their early controlling caregivers. As people with OCDs need to feel more of their emotions, we help them to name what emotions they are experiencing, then help them to accept and express them openly and neutrally, without shame, without trauma, without resorting to any of the OCD mechanisms. And we discourage them from giving justifications for their OCD behaviors. In other words, we don't want them to reason or intellectualize to justify their behaviors. And lastly, we want to refuse to give reassurances that the OCD people often seek. Since OCDs worry that their unrealistic obsessions may come true, they often seek reassurances that their fear will not materialize. Reassurances block recovery as they are a type of compulsion to give temporary relief from their fear. OCDs want to hear a reassurance such as, oh, there is no need to worry. Nothing bad will happen. Instead, we ought to say to them, I think you are asking for a reassurance. Reassurance is not helpful, but harmful to your OCD. Therefore, I'm not going to respond to your requests. So with this, we come to the end of this month's teaching. I wish to thank you for watching our SSC series. This is session number 8, and the topic is Obsessive-Compulsive Disorders, or OCD. To read a case study of a OCD and how it is addressed, kindly refer to our SSC blog V08. This blog is entitled The Work in Progress of an OCD. It is accessible as follows. To receive our latest free monthly video teachings, case study blogs, emails, pro bono counseling sessions, and links to our weekly conversations for sharing and consultations, kindly subscribe to our SSC website at www.safespacecom.org. I look forward to seeing you again. Bye for now.